In the last few sessions, we've talked about the pathology, assessment, and management of arterial ulcers and venous ulcers. And today, we're going to talk about the pathology, the clinical presentation, and the management of neuropathic ulcers. As you already know, neuropathic ulcers are very common, especially in the diabetic population. Now, what is neuropathy? Well, that's pretty easy to figure out just from the term. Neuro means nerve, and pathy means damage. So neuropathy is a state of nerve damage. Very common among diabetic patients, especially those with long-standing type 2 diabetes associated with chronic hyperglycemia. We don't totally understand the pathology of the development of neuropathy, but one theory is that when you have chronically high glucose levels, that glucose passes into the cell, specifically the nerve cell. There's an enzyme within the nerve cell, aldose reductase, that changes the glucose to sorbitol. You already know sorbitol is a very powerful osmotic agent that pulls fluid into the cell, causes a lot of swelling. That compromises nerve function. In addition, a lot of diabetic patients have variable degrees of vascular disease and vascular compromise. And one thinking is that damage to the small vessels adversely affects nerve function. We know that there's a definite link between the duration of the diabetes and the level of glycemic control and the risk of neuropathy. So certainly in terms of preventive care, we're constantly talking to our patients about the importance of tight glucose control, partially because of its ability to significantly reduce the risk of neuropathy. Now, other patients can develop neuropathy. You can see this in patients with B12 deficiencies. You can see it in patients with other neurologic conditions and metabolic conditions. But it's most common in the diabetic patient population. Most of us, when we think about neuropathy, we think about loss of sensory function. But remember, we have three types of nerves. We have sensory nerves, we have motor nerves, and we have autonomic nerves. And nerve damage can affect all three types. Most of your patients who have neuropathy will have not only sensory neuropathy, they'll also have some degree of motor neuropathy and of autonomic neuropathy. So we're going to talk about sensory neuropathy and how it presents, what the impact is, how you screen for it. We're going to talk about motor neuropathy, the impact, how you screen. We're going to talk about autonomic neuropathy, impact, and how you screen. And then we'll kind of put it all together, talk about neuropathic ulcers in general in terms of management guidelines. So let's talk first about sensory neuropathy. So we know our sensory nerves are the nerves that carry messages from our feet to our brain that tell the brain what's going on with our feet. If we have shoes that are too tight, pretty quickly we're going to start getting messages to the brain that I don't care how cute those shoes are and what a good deal they were and how great they look with your outfit, they're killing your feet. That message is very important to you because it helps you self-protect. Once you get the message that these shoes are way too tight and they're pinching your toes or they're rubbing a blister on your heels, it allows you to take action. So you stop walking so much, you start walking more slowly, you find a chance to sit down, you find a chance to take those shoes off, and that protects your tissues from further trauma. Same thing if you're walking down the street and you get a little pebble in your shoe. You immediately recognize that you're walking on a pebble. That alerts you, stop, take off your shoes, shake out the pebble. So sensory awareness allows you to protect your feet from trauma. You step on a tack, you immediately know you stepped on a tack or on a piece of glass. You stop, you pull your foot up, you find the offending agent, you take it out, you determine whether or not you have any kind of wound that needs to be managed. But if you did not have functional nerves, you would not get those messages. You would keep wearing those really cute but too tight shoes until you had developed ulcers or even deeper wounds. You would keep walking on that pedal despite the fact that you're sustaining progressive tissue trauma. You would not be able to self-protect. So sensory awareness is very important. There's two ways that sensory neuropathy can present. The first is with paresthesias. And patients do know when they have paresthesias. These are abnormal sensory signals. So these are patients who complain of burning, tingling, electric shock kind of pain. They'll frequently tell you it's even worse at night. I can't sleep. I have to get up and kind of walk that pain off. Drives them crazy, and you can understand that. And paresthesias are very difficult to treat. So some patients will respond to medication, and we would always refer a patient so they could be evaluated. They could be put on a trial of medication like gabapentin, Neurontin, Lyrica, one of those medications. So paresthesias, very difficult for the patient, cause a lot of discomfort, compromised quality of life. What we worry more about is progressive anesthesia. With progressive anesthesia, the patient loses that protective sensation. They lose awareness that their shoes are too tight, that there's a rough spot in their shoe, that there's a pebble in their shoe, that bath water is too hot, that the pavement is too hot. All of the things that we recognize immediately and that we use to protect our feet, they lose that. That makes them extremely high risk for painless trauma, unrecognized trauma. We don't even recognize most of the time how important this sensory awareness is. But if you think, you put these cute shoes on at 7:30 in the morning, but by 9 o'clock your feet are killing you, you immediately modify. And that protects your feet for the rest of the day. You modify your stance, so you find a way to stand on your left foot and then your right foot. You find a way to slide your shoe off, all protecting you. But if you never got that message and you wore those shoes from 7:30 in the morning till 5:30 in the afternoon, by the time you got home, you would have significant damage to your foot. So progressive anesthesia causes progressive increase in the risk for painless trauma. If you ask a patient, do you have any loss of sensation, they'll probably say no, because you don't recognize what you don't have. So it's very important for us to routinely screen our diabetic patients for loss of protective sensation. And the way we do that is with monofilaments. And you'll get to practice this when you're on site, but I'm going to go in and show it to you. So the monofilament that we use to protect for, or to screen for loss of protective sensation is a 10-gram monofilament. It's like a piece of fishing wire. It's been carefully calibrated. The patient with normal sensation, if you push this against the bottom of their foot with enough force to turn it into a C, they will feel it. So we tell a patient, we show them on their hand what it feels like, then we tell them to close their eyes. We put their foot on the table. We do not touch their foot because we do not want to compromise the results of the test. Then we're going to check at 10 points typically. If there's callus at any point, we usually skip that because we won't get accurate results. But you're going to test the first, third, fifth toe pad, first, third, fifth metatarsal head. At midfoot, you're going to check medial and lateral. You're going to check over the heel. And then on the dorsum, you're going to check between the first and second toe. If the patient is able to recognize every time you touch, so you tell them, close your eyes, I'm going to be touching different areas on your foot. You tell me when you feel it. So you want them to say yes, 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 I feel it, I feel it, I feel it, yes, yes, I feel that, I feel that. Any areas where they fail to respond, those are areas where they have a loss of protective sensation. Some centers, in our center we do this, we also carry the 100-gram monofilament, 10 times stiffer than the 10 gram. This is also known as a 6.10. If they fail to respond to this, they are considered to be totally insensate. So if they fail to respond to 5.07, they have loss of protective sensation. It means they might feel some things, but they're not going to feel tight shoes, repetitive rubbing, those kinds of things. But if they fail to respond to 6.10, those are the patients who can step on a nail and not recognize it. Those are the patients who can put their foot in a very hot tub of water and not recognize it. These patients are even higher risk. So your patients who are totally insensate are even higher risk than your patients who have lost protective sensation but still respond to the 6.10. So again, you'll get to see that on site. Now there's another test that we can do, and that is a test for vibratory sense. Vibratory or loss of vibratory sense usually precedes loss of protective sensation. So if you have totally normal nerve function, you'll recognize vibration, you'll recognize 5.07. If you're beginning to develop neuropathy, you'll lose vibratory sense, but you'll retain response to 5.07. If you have more advanced neuropathy, you will have lost vibratory, you will have lost 5.07, but you'll retain 6.10 or 100-gram monofilament, the response to that level of testing. Very severe neuropathy, you have none of these. Your foot is insensate. Now, the value of using the tuning fork to test for vibratory sense is it alerts you and the patient to the fact that they're developing neuropathy. And at that point, you want to reinforce how critically important it is to maintain tight glucose control to try to prevent any further progression of the neuropathy. Now, we will practice this when you're on site, but basically what you do, you hold the tuning fork by the tip. You never hold it by the 2 tines here because that will stop the vibration. I've done that a lot of times. So you hold it, you smack it until you can see it visibly vibrating. You put it against the bone on their foot, either at the base of their great toe or the medial aspect of the first MTP joint. You ask them what they feel. They should say vibration. You ask them to keep their eyes closed. You pinch the tongs together and you ask them to let you know if there's any change. So I'm going to go through that with you again. I show them on their hand, then I have them close their eyes. I smack it till it's vibrating. I put it over their bony prominence. I ask them to tell me what they feel. If they say vibration, I ask them to tell me if it changes. I then stop it, and I'm waiting for them to say it stopped vibrating. With a diabetic patient, many times they just feel the pressure, they don't feel the vibration. In that case, this is what might happen. So I smack it, I put it on, they're like, I feel it, I think I feel the vibration. They're just feeling pressure. You stop it, they say nothing until you move it, and then they say, oh, it stopped. They were feeling pressure. So what's the value of testing for vibratory sense? It alerts you and the patient to the onset of neuropathy and allows you to ramp up your education and the patient to ramp up their efforts to maintain tight glucose control to hopefully reduce the rate of progression or prevent progression. Now, the other thing that can happen is they can lose position sense or proprioceptive sense. And you think when you're going down the steps, this is a good example, and you've got your arms full, so you can't really see where your feet are, and you know how you kind of feel your way down the steps because you're not holding onto the side rail and you can't see your feet, so you kind of feel your way down. And you know how if your foot gets right on the edge of the step, you immediately recognize that, and that tells you to lean back lean against the side rail. That helps protect us from falls. Once diabetics lose that, they become higher risk for falls because they don't really know where their feet are in space and in relation to other objects. The best way to test for that is to have the patient close his or her eyes. You tell them, I'm going to move your great toe. I'm going to move it either towards you, down away from you, to your right, or to your left. I want you to tell me which way I'm moving it. The patient with intact proprioception will be able to tell you. The patient who has lost proprioception will not be able to tell you. What do you do with the information? If they have intact position sense, intact proprioception, I don't have to tell them anything. That's okay. They can continue to self-protect. But if they've lost this, I have to tell them you're higher risk for falls. Be very careful going down steps. You need to watch your feet, watch where you're going, hold on to the railing. Be very careful when you're walking on uneven terrain. Watch your feet. Now these are just examples of neuropathic ulcers. The patient on the top left had a little pebble caught in the lining of his shoe, but he didn't recognize it. So when he put his shoe on that morning, he had intact skin. By the time he took his shoe off that night, he had an ulcer extending into the subacute tissue. That would be a Wagner level 2, which we'll talk about later. The patient on the top right had a combination of motor neuropathy causing hammer toes. We'll talk about that in just a minute, and sensory neuropathy. Very bad combination because now his toes are pulled up like this and they're rubbing against the tops of his shoes, but he doesn't feel it. And he didn't recognize it until his wife said, "Why are your socks gooey? Why are they sticky? What's going on? What's going on with your feet?" And she looked at his feet and she's like, "You've got sores on the top of your toes." He had no idea. This is common. You see how all of the toes look bruised and red? That's because diabetics are frequently wearing shoes that are too small. Because they don't have normal sensation, they don't recognize that their toes are rubbing against the shoe. A tighter shoe actually gives them more of a sense of security because of that diminished sensory awareness. So it's very important for us to make sure that patients who have any sensory neuropathy are being professionally fitted for their shoes. The only patient with diabetes who can safely buy their shoes off the rack are patients who have no neuropathy. They have intact vibratory sense. They respond to 5.07. They know where their toes are. So if you have women and you're trying to motivate them to maintain tight glucose control, you can say, do you want to still be able to shop at Designer Shoe Warehouse? Tight glucose control helps protect your nerves, helps maintain your awareness of what's going on with your feet, and helps protect your privileges for off-the-rack shoe shopping. This patient should not be doing off-the-rack shopping. This patient had very advanced neuropathy, no response to 6.10, stepped on a nail, the nail drove a deep hole into the foot. The patient didn't know it until he tried to take his shoe off and couldn't get it off and ended up with a through-and-through injury. What about motor neuropathy? Motor neuropathy involves damage to the nerves that control the muscles. The muscles in the foot maintain normal contours of the foot and the toes and maintain normal weight bearing. So when you get damage to the nerves, the motor nerves, then you get alterations in foot contours. You start to get foot deformities. So you see on top you've got severe hammer toes. And you can see why that would increase the risk of damage because now you have toes that are rubbing against the tops of the shoes. You can also get damage from the toes pushing against the foot, and you can get damage right here from rubbing against the shoe. You also get changes in weight bearing as the contours of the foot shift. Then you're going to get abnormal pressure points frequently over the metatarsal heads. So a lot of times you'll get an abnormally pronounced arch, and you'll get very pronounced pressure over the first or third or fifth metatarsal head, so a lot of weight bearing over the met heads. The first sign that you're getting increased trauma over the met heads is callus formation, because you think about when you walk, you get shear and friction, shear and friction, shear and friction, but normally you're protected because you've got those fat pads over your metatarsal heads, plus you know what's going on with your feet. So if your shoes are not fitting correctly, you get that feedback and you change those shoes. But the patient with neuropathy does not get that feedback, and so in addition to having abnormal pressure points, they have loss of sensory awareness. They get increased friction and shear, friction and shear, friction and shear. First they develop a callus, and then they end up with an ulcer in the middle of the callus. In terms of screening for motor neuropathy, it's just visual. Primarily, you're looking for abnormal contours, you're looking for hammer toes, overlapping toes, you're looking for abnormally pronounced arch, callus over the metatarsal heads. You can also check muscle strength by having the patient push against your hand, or by having a patient pull against your hand. But the primary screening is visual assessment for deformities or callus formation. Then the third type of neuropathy is autonomic neuropathy, and this is damage to the autonomic nerves, and the autonomic nerves control two things. They control the function of the sweat glands, and they control the size of the blood vessels. Now, we commonly talk about diabetics having very dry, cracked feet. That's from damage to the autonomic nerves that control the sweat glands. So two things can happen. The most common is that they have marked reduction in sweating, and so they have very dry, cracked feet. The other thing that can happen is they can have excessive sweating, so that their feet are constantly wet. They're much more prone to fissure formation in that case. But for most patients, it's that dry, cracked feet. The other thing that autonomic nerves do is they control the size of the blood vessels. So the blood vessels dilate when you're very active, you're running, you're race walking, and you need increased blood flow to the feet, to the muscles of the feet. And then the vessels partially constrict when you're at rest and the metabolic demands are reduced. One of the things that can happen with autonomic neuropathy is that the vessels become chronically dilated. Now, when you first think about that, you think, well, isn't that a good thing? Wouldn't you much rather have too much blood flow than not enough? But here's the problem. In each foot, you have 26 bones to maintain the structure of the foot. Most of those bones are very small, and they work together and with the muscles and the fascia to maintain or to support your weight, support activity. If you have high volume blood flow on a constant basis, what happens is that those bones become demineralized, they become thinner. It's kind of like water against rock, gradually causing erosion. So those bones gradually become eroded, become very thin, very vulnerable. And then what can happen is that minor trauma, stepping off a curb the wrong way, where you hit the foot wrong or you twist the foot, can cause a fracture. Now, if the fracture is recognized, it's not such a problem. If you step off and you break a bone in your foot and you're like, whoa, what did I do to my foot that's killing me? And you immediately stop bearing weight, and you get somebody to go get the car, and you hop to the car, and you go in and you get seen, and you get your foot casted or whatever, okay, nothing terrible happens. That bone heals, and the structure of the foot is maintained. But think about the fact that the patient with autonomic neuropathy almost always has sensory neuropathy. So when they step off the curb wrong, and they catch their foot at an angle and they break that little bone, instead of thinking, oh my God, what did I do to my foot? They're like, I hope nobody saw me. And guess what? They keep walking because they don't feel it. It doesn't hurt. So now you've altered the structural integrity of the foot because you have a fracture, but you keep walking on it, which causes more and more trauma. And over time, you get repetitive fractures, you get loss of the normal contours. So here's normal contours. Here's what you see with a Charcot foot. You've lost the arch, you've lost the normal and structural integrity of the foot. Now you have totally altered weight bearing, and very common to get ulcerations. So how do you screen for autonomic neuropathy? You look for significant changes in the contours of the foot, loss of the arch, and development of that Charcot contour. And you also look for very dry or very wet skin. Okay, now we're going to just summarize the types of damage that can occur in a patient with neuropathy and how you manage. By far, the greatest risk is painless repetitive trauma. And we've already talked about what happens with poorly fitting shoes, okay? The patient doesn't know their shoes don't fit. Every time they take a step, their feet are either sliding or being compressed, and they get damage to the soft tissue. Where is damage going to be seen? It's going to be in an area in contact with the shoe. So it's going to be the heels, the tops of the toes, the plantar surface or the periphery of the foot. Some area in contact with the shoes that's exposed to constant friction, shear, friction, shear, friction, shear. On the plantar surface, it's much more likely to be over the metatarsal heads, because if you think when you're walking, you do heel strike, you roll up on the metatarsal heads. That's where the greatest weight bearing occurs, and then you toe off. When you get motor neuropathy and you get changes in foot contours, most commonly what happens is you get increased pressure over the metatarsal heads. When you get increased pressure over the metatarsal heads, that means with every step there's increased friction, increased shear. And the end result is a callus and then an ulcer. You can also get ulcers between the toes where they're rubbing against each other, especially if the toes start to overlap or become, if you develop hammer toes that are clustered or pushed very closely together, they can start to rub. How do you prevent ulcers that are caused by painless repetitive trauma? How do you protect your feet? You use shoes wisely, okay? Shoes can protect your feet, but they have to be professionally fitted. They have to be worn consistently. You always want to shake them out before you put them on to make sure there's nothing in them. When you buy new shoes, you have to break them in gradually, and you need to avoid heels. So correctly fitting shoes. Patients who have altered sensation cannot buy their shoes off the rack. They don't know whether those shoes fit or not. You think what happens when you go to buy new shoes? You put on shoes, you walk around in them, you're like, I don't know, this one feels kind of tight. Maybe it'll stretch out. Probably not. But you're walking around in those shoes for a reason. You're trying to determine if you have a good fit or if they're uncomfortable. If they're uncomfortable, it's because they don't fit correctly. So we can detect poorly fitting shoes because we have intact nerve pathways. The diabetic patient with sensory neuropathy cannot. They cannot rely on that. So they can't put on the shoe and say, well, it feels good. Of course it feels good. That's the problem. It looks good and it feels good. No, they have to be professionally fitted. So they have to have somebody who measures their foot, puts them in the shoe, checks a number of different parameters to make sure that there's no compression of their toes or the sides of their foot, that there's no rubbing against the heel. If they have hammer toes, they have to have an extra depth toe box. If they have altered contours, they need specially designed insoles so that they have enough protection. Heels, significantly increased pressure over the mat heads. So even a 2-inch heel, I think it's 57%. I was going to look and see. I think it's on here somewhere. Yes. Even a 2-inch heel increases pressures over the metatarsal heads by 57%, that whole shear friction when you're walking. So our patients should not be wearing heels. Now we're going to have women who are going to special events. Yes, they're going to want to wear low heels to special events, but you tell them, do what working women do every day. Wear your flat shoes that protect your feet to the event, in your car, to the event, okay? Put on your heels just before you go into the wedding, the service, whatever it is. And as soon as the special event is over, take off the heels and go back to your flat shoes. You've got to protect your feet. If a patient has a history of ulcers over the metatarsal heads, then they need what they call rocker bottom shoes that totally offload pressure to the bottom of the foot. Rocker bottom shoes are kind of fixed, I'm going to show you, on a walker. This is one of your removable cast walkers, and this is a rocker bottom shoe. And so what happens, because of the contour of the shoe, you get very little pressures over the metatarsal heads, okay? The foot does not bend at the ankle, and you get practically no pressure over the metatarsal head. So when you're here on site, if you want to see exactly how this feels, you can ask us to get it out. You can put your foot in it, and you can see that when you're in a rocker bottom shoe, it stops or minimizes pressure over the metatarsal heads. It changes your gait and stops you from doing that acute flexion that causes increased pressure, shear, and friction over the metatarsal heads. So you protect your feet. When should you be wearing shoes? Anytime they're in contact with any surface. If you're out of the bed, you should be wearing shoes to protect your feet. Well, what about at home? Wear shoes when you're out of bed. And they have to be more than little slippers. They have to be shoes that have enough sole to give protection. Your second major intervention to protect yourself is to visually inspect your feet every day. Look for any evidence that you've sustained any trauma, any areas of redness. Also, ideally, check the temperature of your feet. They have skin thermometers. They used to have some that were very inexpensive at Radio Shack. Now those very expensive ones have gone away, so the ones that are readily available, I think, are typically between $50 and $100. But it's a wonderful investment for a patient with diabetes because it tells them what their nerves would normally tell them. If their feet are inflamed, if there's tissue inflammation from poorly fitted footwear, when they're checking the temperature at multiple points on the bottom of the foot, the area of inflammation is going to have a higher temperature. So if there's an area where the temperature is higher by a level of 4 degrees Fahrenheit, that signals an area of inflammation that has to be very carefully monitored. If it doesn't quickly resolve, they need to get in and be seen. Now, a lot of times there's confusion as to whether or not neuropathic ulcers are pressure ulcers. Remember that pressure ulcers are caused by sustained, unrelieved pressure. Shoe-related trauma is very rarely pressure. It's almost always a friction shear mechanism of injury, repetitive friction and shear. Yes, pressure plays a role because you're walking, but it's not sustained, unrelieved pressure. It's much more the shear and friction. But if you have a diabetic patient with neuropathy and they're in bed, are they higher risk for heel ulcers? Or are they higher risk for ulcers over the ankle bones, the malleolus line? Absolutely. Will they recognize impending ulceration? No. Critical to consistently float their heels, float their feet so that their ankles aren't in contact with the bed and their heels are not in contact with the bed. The other mechanism of injury is direct penetration by a sharp object. This can happen to people with or without neuropathy. The issue is that if I do not have neuropathy, I recognize it immediately and immediately take appropriate action. But if you have a patient with neuropathy, they can step on a tack, they can step on a needle, they can step on a piece of glass and never recognize it and keep walking on that foot, and that object gets embedded into the soft tissue, and they don't recognize that anything's going on until they have a hot foot, at which point they've long since forgotten that they might have had any injury. You know, one lady's like, when we x-rayed her foot, she's like, oh, is that where that sewing needle went? I've looked everywhere for it. People have come in with glass embedded in their foot. When it was finally, the ulcer was probed, the glass was identified and removed, the patient's like, I thought I swept all that glass up. I didn't know I got any in my foot. Well, what does that tell you? They were not wearing protective footwear, right? So again, how do you protect against direct penetrating trauma? You never ever go barefoot. Never. You shake out your shoes. You check water temperature. You do not use any sharp instruments on your feet. And if you have neuropathy, and certainly if that neuropathy is complicated by any degree of lower extremity arterial disease, don't get your nails done at the mall because you can't risk trauma and possible infection. And finally, patients who have very dry, cracked feet are at risk for fissure formation, cracks. If they develop fissure formation, the problem is now they have a break in the skin that allows bacterial penetration. And again, because they also have sensory neuropathy, they're not even aware. If they didn't have sensory neuropathy, they'd know they had a crack in their foot and was very uncomfortable, and they would get treatment. When you don't know, you don't get treatment. Now, if you have a patient who has thick, very thick callus on the bottom of their feet, their heels, you want to pare that callus down or sand that callus down. You want to look for any fissures. If they have fissures, once you shave down the calloused area as much as possible, flush it really well, clean it really well, then hydrocolloid is a very good treatment because it keeps all the bacteria out, contours very well to the area, maintains a moist surface until that fissure resurfaces. Then prevention, of course, using a pumice stone after their shower. We talked about vinegar water soaks when we talked about anatomy and physiology and keeping the skin healthy. Usually you would only do vinegar water soaks 2 to 3 times a week, 10 to 15 minutes. Check the water temperature and then dry well between your toes. And of course, using emollients. Now we have to be aware that neuropathy and lower extremity arterial disease can coexist. So, of course, when we're assessing a patient with a lower extremity wound, we don't just walk in and say, oh, you've got diabetes, it's on the bottom of your foot, it's clearly neuropathy. No, we always assess not only sensory motor function, we always assess perfusion. So we're always checking status of skin, hair, and nails. We're always looking at color in response to elevation and dependency. We're checking venous filling time and cap refill. We're checking pulses. We're doing an ABI. If the patient has neuropathy alone, if all of my vascular parameters look normal, good pulses, warm feet, no color changes with elevation and dependency, hair on their toes, ABI 0.93, then my focus is going to be on offloading glucose control wound care. If I have a combination of neuropathy and lower extremity arterial disease, so I clearly have neuropathy, but I also have arterial disease. I've got that thin skin. I've got loss of hair. I've got some degree of elevational pallor and dependent rubor. I've got diminished pulses. My ABI is down in the 0.6 range or even lower. Then I have to do 2 things. I have to get that patient to see vascular. I have to do everything possible to improve perfusion, as well as providing tight glucose control and offload. Now, the characteristics of neuropathic ulcers, just to recap, where will they be located? Neuropathic ulcers are always on the foot. They're not between the ankle and the knee. They're on the foot. And they're always in areas where there's contact between the foot and the shoe, unless it's caused by direct penetrating trauma. And even then, that's the plantar surface. The wound base is usually red unless they have coexisting ischemia. They're usually wet. And over the med heads, very common to see associated callus. So now let's talk about management. We talked a lot about prevention. Now we're going to talk about management. Just like we talked about with a patient with a pressure ulcer, can you get that pressure ulcer to heal as long as the patient is lying on that surface? And the answer, of course, is no. The corollary to that, if I have a wound that is caused by repetitive trauma, friction shear, rubbing, 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 can I get that wound to heal if the patient's still walking on the ulcer and exposing the area to that repetitive trauma? And the answer, of course, is no. So if that patient with a neuropathic ulcer on the bottom of their foot walks into your clinic week after week, they're never going to heal the ulcer. Offloading is critical. Now, there's more than one approach to offloading. The total contact cast, like you see on top, is considered the gold standard. But if that's not feasible in your setting, you can also use removable cast walkers. These two give you comparable results. If neither of these are feasible, the other options are a poor man's total contact cast or a half shield. We're going to talk about each of those. So the total contact cast, as we've said, is the gold standard. In studies, use of total contact cast gives you the highest healing rate, 89.5%. You can see the advantage. What you do, you pad the foot, you pad all of the bony prominences, you dress the wound, you apply a cast, you put, it's a walking cast, so you've got this walking pad on the bottom. The metatarsal heads are totally offloaded. This is particularly appropriate for the patient with an ulcer over the metatarsal heads. That's where ulcers are most likely to occur. So you can see, first of all, you've got a rocker bottom, so there's no flexion. You cannot end up with pressure on the metatarsal heads. The metatarsal heads themselves are totally offloaded. And because the cast is reapplied in clinic once a week, it builds in compliance. And that's a huge element. So you are keeping the patient off the ulcer. What are the disadvantages? Well, you have to have someone who's skilled in cast application because you have a patient with neuropathy. If you don't do appropriate padding, if you inadvertently get too much pressure over a bony prominence, they come back and they have a new ulcer over the heel, over the ankle bone. So you have to have someone who's skilled. And it is time consuming to apply a total contact cast. Now there's a new device on the market, I think it's called Easy Cast, that certainly makes it faster. But it comes down to, do you have someone who's skilled in cast application? Ideally, it's someone who does this all the time. If you do this occasionally, no, you're not going to be skilled enough to get good outcomes. Also, you don't cast an infected or ischemic wound because there's no way to monitor it. The cast stays on for 1 to 2 weeks. What if the patient doesn't come back? So we do not do total contact cast for infected or ischemic wounds. Well, what about a removable cast walker? Some of you might have been in a removable cast walker because of an orthopedic injury, like an air cast. Okay. Well, the advantage is that it gives you very comparable results to a total contact cast. You can send the patient to a center, get them fitted for this, and essentially it is the same mechanism of action as a total contact cast. You've got the rocker bottom, you've got offloading of the metatarsal heads. Healing rate's about 65%, The problem is that it's removable, so compliance drops when you go from a total contact cast to a removable cast walker. Some clinicians, some centers put their patients in removable cast walkers, but then apply a few layers of cast material around it to turn this into a non-removable device until the ulcer is 50% healed, at which point they convert it to, they stop the cast application so that it truly does become a removable cast walker. If the ulcer starts to deteriorate, you're right back to putting on the removable cast walker and applying casting material on top to make it non-removable. So the disadvantages are cost. If you have a patient who has insurance coverage, you're probably going to be able to get this covered. But compliance, that's the huge issue. It's removable. So you either have to have a patient who's very well educated and very motivated and who understands that, yes, I have to wear this all the time. And if you've been in one of these, you know it totally changes your gait. You have to use a very short stride. It's heavy. It makes you think twice before you walk anywhere. But that's part of the benefit. What are you trying to do? You're trying to offload. What else can you do? Well, there's something called a poor man's total contact cast that can be done in centers where total contact casting is not an option, either because of staffing issues, cost issues, time issues. And maybe your patient does not have an insurance benefit that covers the removable cast walker. Now, it started out with just anecdotal support, but now more and more is being incorporated into podium presentations and into the literature as an alternative for a patient who, for one reason or another, is not a candidate for a total contact cast or removable cast walker, usually cost issues, but who is willing to come back to clinic weekly. And this is what you do, and we'll practice this when you're on site. But you take this 1/4 inch adhesive felt. It's very dense felt, totally non-compressible. You shape it to fit the top half of their foot and up onto their toes. You cut out a U-shaped area right around the ulcer, and we'll show you how to make sure that your pattern is applied correctly. Then you're going to take off this paper backing. Sounds easy. Usually we put skin prep down around the ulcer. Then you're going to apply this, okay, to their foot. Now you can dress the ulcer. You do a bulky wrap around it, and you put them in an orthopedic shoe. And the amazing thing is when they stand on it, their ulcer is lifted. Their foot is lifted up off of the underlying surface. So there's no pressure on the ulcer. Because it's U-shaped, you maintain perfusion to the area. It does not act like a donut. So poor man's total contact cast. You can do this, and you should do this if the patient's not a candidate for another type of offloading device. And then the last option is the half shoe. It's intended for patients who have ulcers over the metatarsal head. So you can see the potential advantage, but there's a lot of disadvantages. There's no protection for the toes. The top of the shoe is open. A huge issue is that there are safety issues because it changes their gait and can increase their risk of fall. So again, you have to evaluate, is this going to work for this patient? Are they going to wear it consistently? Do they modify their gait, their stride appropriately? Are they safe to use this half shoe? But you have to come up with a way of offloading or the wound will never, ever heal. We've already talked about if you have coexisting lower extremity arterial disease, how critical it is to get vascular involved. You already know the guidelines. If you have a wound with ischemic etiology, and the wound is covered with dry eschar and it's uninfected, you're going to leave it alone until you get that patient worked up. You determine whether or not they have enough perfusion to support healing or whether or not they can be revascularized. Tight glucose control, absolutely essential. We've talked about that in previous classes. We're almost always talking about diabetic patients when we're talking about neuropathic ulcers. And every time we see the patient, we have to be talking to them about glucose levels, the importance of very tight glucose control. Many times you'll find that patients consider the ulcer to be totally separate from their diabetes. I've had patients say, when I started asking them about their diabetes, oh, I'm not here for that. I'm here for this ulcer. I go to Dr. So-and-so on the 4th floor for my diabetes. That's how they separate it. 4th floor, they go there for their diabetes. 3rd floor, they come for their ulcer care. So we have to make that connection for them. We have to make sure they understand how critical tight glucose control is. Many times short-term contracts are very effective, asking people, can you just work with me to maintain really tight glucose control until we get this wound healed. I'm talking 6 to 8 weeks probably till we get this wound healed. But I can tell you if we can't keep your glucose levels controlled, it's going to interfere with your ability to make new tissue, to make new skin, to fight infection, everything we have to do to get that wound to heal. And most of the time, people will get on board, at least short term. Topical therapy, we've spent a lot of time talking about topical therapy already. I'm just going to recap, looking at issues that are specifically relevant to the diabetic patient population. If you have a wound that was maybe caused by neuropathy, but that is complicated by ischemia, and that wound is covered with dry eschar, and there are no signs of infection, you're going to leave that dry eschar in place. You're going to paint it with betadine, leave it open to air, or cover with a dry dressing until further workup is done. But if you have an open wound, or if you have a wound where you have already determined that healing is your goal, you're going to follow all the principles of moist wound healing. Keep the surface moist, manage your exudate, prevent bacterial invasion, provide atraumatic removal, all of those things. What's different is that by definition, your diabetic patient population is much higher risk for infectious complications. So in selecting dressings that provide for exudate control and for maintenance of a moist wound surface, we almost always elect to use an antimicrobial dressing. So I might decide that I'm going to use an alginate because this wound is moderately exudated. I want to manage the exudate, keep the surface moist. Well, I'm probably going to use a silver alginate or a silver hydrofiber or a foam dressing with an antimicrobial agent to reduce bacterial counts on the wound surface and reduce the risk of infectious complications. If I have necrotic tissue and my wound is open, if I have necrotic tissue and my goal is healing, if I have necrotic tissue and my wound is infected, I must debride. So if you have an open wound, of course, you're going to move ahead with eliminating necrotic tissue, managing bacterial loads, managing exudate, keeping the surface moist. It's too late to leave eschar in place because you have an open wound. Maybe it's partially covered with eschar, but the rest of the wound is open. Open wounds, move ahead with standard wound care, heavy focus on eliminating necrotic tissue, heavy focus on managing bacterial loads. Okay. If you have a wound and the goal is healing, and there's a lot of necrotic tissue in the wound bed, or is covered with necrotic tissue with eschar, but your goal is healing, you're going to debride. There are some studies that show that with diabetic ulcers, with diabetics who have foot ulcers, that early aggressive debridement of all necrotic tissue is associated with better outcomes. So if your goal is healing and the wound is necrotic, ideally you would like to get that wound surgically debrided. If you have an open wound and you're pushing for healing, get it surgically debrided if the patient's a candidate. If the patient's not a candidate for instrumental or surgical debridement, you're probably going to go with Dakin's because it will dissolve the necrotic tissue and control bacterial loads. If your wound is infected, obviously the necrotic tissue has to be removed. Again, if the patient's not a candidate at this point for surgical intervention, you would usually use Dakins because it can dissolve the necrotic tissue and kill the bacteria. Once you have infection under control, hopefully they will take them to surgery, or they'll infiltrate the area with xylocaine and do excisional debridement in the clinic or in the operating room. Also, very aggressive treatment of infection. This will be one of your test questions, actually. What's particularly important within the area of topical therapy? What elements are particularly important when you're managing foot ulcers in the diabetic patient population? And the answer is early aggressive debridement if the wound's infected, if the wound's open, or if your goal is healing, and aggressive management of infection. So every time you change the dressing, you're going to be very carefully assessing that wound for any evidence of infection, and you're going to remember that diabetics can have compromised immune function. So it might not be bright red. If you see a faint halo of erythema extending more than 2 centimeters from the wound edge, you're going to treat that patient for invasive infection. Patient education, obviously, they have to be on board. They're the most important team member. They have to understand how important it is to stay off the ulcer, to stay in that removable cast walker, to use that half shoe correctly, to show back up for their clinic appointments, to maintain tight glucose control, all of those things. And then once you get the ulcer healed, you're going to send them to be fitted for an appropriate shoe. Remember that patients who have had ulcers over the metatarsal heads are going to need a shoe that is a fixed shoe that doesn't allow the same level of flexibility. You do not want them creating a lot of pressure over the metatarsal head, so you need that rocker bottom type shoe. That means they have to be professionally fit for a shoe that minimizes the risk of a recurrent ulcer. So in most centers, what they do, once the ulcer is healed, they keep the patient in that removable cast walker, send them to be fitted for appropriate shoes. Do not take them out of the removable cast walker until they get the new shoes. And even then, they're going to need to go back and forth because you have to break in new shoes gradually. Usually they recommend no more than 2 hours at a time. 2 hours at a time, you've done well for several days. Now you can go to 4 hours at a time. Doing okay, now you go to 6 hours at a time, etc. Obviously, we're monitoring them. If they don't progress normally, we're going to think about, well, what active wound therapies might be beneficial for this patient. If there's an ischemic component, maybe hyperbaric oxygen therapy would be helpful. If they're slow to granulate, matrix dressings can be helpful, like Oasis, because it provides that scaffolding that allows the cells to migrate and also donates growth factors. Human skin equivalents, if you get the wound close to the surface and it's just very slow to epithelialize, maybe you can use a 2-layered or bi-layered equivalent like that, Apligraph. If you have a wound with depth, you might try Dermagraft or Graft Jacket. And I just wanted to put this in. I think you want to know this Wagner classification scale. It is the most commonly used classification scheme for diabetic ulcers, just like the NPUAP staging system is used for pressure ulcers. So you can see grade 0 is any patient who has a healed lesion. A pre-ulcerative lesion, like a callus over a metatarsal head, would be a pre-ulcerative lesion. An area of erythema would be a pre-ulcerative lesion. They're also categorized as grade 0 if they have bony deformities, like hammer toes. Grade 1 is a partial thickness wound. Grade 2 goes into the subacute. Grade 3, you have infection. You have osteitis, abscess, osteomyelitis. Grade 4, you've got necrosis. And grade 5, you've got extensive gangrenous changes of the foot involving or requiring disarticulation. So we've already talked a little bit about follow-up care. We've gotten the ulcer to heal. They have to be referred to a podorthist or an orthotist to assure proper footwear. They have to increase walking time gradually. You don't say, okay, you're healed, strap on your shoes, head out into the woods. You're like, okay, you're healed, but this new tissue is very fragile, and we have to very gradually increase your weight-bearing periods. So you're going to start out very, very slowly. Most of them are going to need those extra depth shoes with customized insoles, appropriate socks without seams that keep the skin cool and dry. So socks that provide appropriate microclimate, socks that are intended for diabetic patient use. And of course, daily foot checks, daily foot care. Okay, thank you very much.